Okay, so any questions from anything we've covered previously? Okay, everyone's been reviewing their antibacterials over the hurricane break and everything. I hope at least a little bit of stuff you can look at, so it's not total system shock when you get back into it. So, okay, so anyway, we're going to continue on talking about some finish up our derm section. So we have a couple of topical antifungals. Again, we see several azoles being used here. Again, with the topical product, what's the benefit of using a topical antibiotic or antifungal here versus like a systemic one? Less absolutely. So less side effects is really the big thing here. So again, even though these are working against like fungal P450 enzymes systemically, they can still affect humans, which is why you see a lot of drug interactions here. So systemically giving a lot of these azoles can lead to some issues with drug interactions and whatnot. But fortunately, if we're doing topical, you don't have to worry about that quite so much. You will see some of these, including things like clotrimazole, ketoconazole, miconazole. These oftentimes get used for either topical fungal infections or sometimes for vaginal uses as well. And then in some cases, you may see them combined with corticosteroids. So, and again, what is the role of a corticosteroid for all these topical conditions? Yeah, anti-inflammatory. So it can decrease a lot of the inflammation, get rid of a lot of like itching, pruritus, things like that that are kind of annoying your patients. Again, with fungal infections, you typically see longer treatment times than you will for bacterial infections. So say like 2 to 3 weeks or so is what you'll see as far as use. And again, adverse reactions systemically topically you don't see a lot of issues. Maybe a little bit of local irritation, but other than that, not a whole lot of side effects, which is good. We also have the Ciclopirox or Penlac. This one is used for nail infections specifically. So it comes as this nail lacquer. You basically just put on just like you would nail polish or something like that. So I'm sure any guys are having to put it on, it's going to be all over your finger. But good thing there's not a lot of toxicity, so you don't have to worry about that if you cannot apply it very well. So again, a lot of times you're going to see that stuff like this is not super effective because one, we mentioned you have to treat for a long period of time, and nail infections typically are much harder to treat than say like just a typical dermal infection. So even then you have to treat for longer than that, several months in a lot of cases. And how compliant do you think patients are going to be with this sort of therapy? Not great, right? They're going to fall off. Usually they'll probably start strong. It's like, any kind of like diet or something like that. You start really strong the first couple of days and you forget about it and you die off, and then the fungus is still going to be there for a while. So that's usually what it's going to be as far as affecting the effectiveness is more patient compliance than anything else. We have a few allylamines. Naphthene and terbinafine, or Lamisil is a common brand name for terbinafine. Again, this is going to be good for again, topical fungal infections. Again, this is working to prevent that ergosterol production, which again is going to help to start to degrade down the fungal cell wall and then eventually have cell death via that process. Let's see. Some other ones you may see, tolnaftate or tenactin. Again, another one here. You notice it has no candidal activity. So again, I'm not going to get super specific on the test as far as like which type of fungus that each one of these is going to treat. Just know that this is oftentimes something you're going to have to look up in some cases. So if you're not, if you're worried about a specific candidal infections like thrush or something like that, like you want to make sure you're using something that actually covers it and not have that kind of hole in therapy there. Another one that we use very frequently, though, for candidal infections, both cutaneous and mucosal, is going to be Nystatin. This one's really good because we don't have a lot of oral absorption for this one. So we will use this very frequently for a lot of our chemo patients who are neutropenic, right? So we've kind of given them chemotherapy, you've kind of wiped out their immune system for all intents and purposes. And so they're very at risk for having things like a candidal, esophageal candidiasis or thrush. And so what's the risk of having an immunocompromised patient with a kind of a fungal infection like that? Go more systemic, right? So you worry about disseminating, getting to a blood infection or possibly down the respiratory tract, and that can be very difficult to treat. So a lot of times we'll give this as a preventative therapy, as kind of prophylaxis, and so we'll have them swish and spit or swish and swallow this Nystatin. Doesn't matter which one you do, because a lot of times you're going to find that it has no good oral absorption, and so you don't have to worry about side effects from that standpoint. So that's why we use that a lot for oral prophylaxis against fungal infections. Okay, next we'll talk about a few topical antivirals. So some of the big ones you're going to run into, and you'll see these being used systemically as well as topically. Acyclovir is going to be a big one. I'm sure a lot of people have heard of Zovirax or Acyclovir before, possibly. Maybe not so much. You have things like Penciclovir, and basically what these are working as are synthetic guanine analogs. And so if you had to guess, how do you think that, how would that work against a virus? Yeah, so it's basically a substitute for guanine in the viral DNA and prevents it from forming new DNA, right? So you see more strand breakage, you have preventing DNA replication, and that kills off the virus eventually. So again, you'll find certain chemotherapeutics that will work for human cells as well, but these are going to be more specific for viral particles. And so Acyclovir, Penciclovir, these typically are going to be active against herpes virus simplex 1 and 2. And so again, they can use these for either type of infection, but a lot of times you'll find like things like Zovirax, we make me apply to like cold sores and things like that, usually be pretty effective. And again, not a lot of side effects, at least when given topically. We'll see this is not the case when we're talking about systemic use of some of these antivirals. We'll talk about those in a later section. We also have Imiquimod or Aldara. This one's kind of interesting because I had a question that came up and said like, well, you know, we saw we had some topical immunomodulators that were trying to suppress inflammation. You guys remember what those drugs were? Yeah, the tacrolimus. You guys remember the other one? Yeah, pimacrolimus. Yeah, so both of those are actually immunomodulators, but this is an important point, I guess, is that modulation can either mean you're inhibiting something or you're stimulating it. And so in those cases, you're actually inhibiting the inflammatory system when you're having cases where you didn't want to use a corticosteroid, but you want to deal with inflammation, like in psoriasis and things like that. This is actually going to be an immunomodulator, but stimulatory to the immune system. And so this is good against certain viral infections, especially against warts. And so this actually will help to stimulate our PMNs. This will stimulate TNF alpha and interleukins, and it's going to be good for either external perianal warts and some types of cancer like basal cell carcinoma. So this is stimulating the immune system to attack these specific types of particles like these viruses or whatever happens to be. And again, here you're going to notice that what's interesting is that as a side effect, you would expect the immune system to be more active, and so that is actually a sign of efficacy here. So the patients can, develop these vesicles, erosions, ulcers. The higher the amount of inflammation they're having, and the higher the side effects, usually the more effective the drug's being. So it's kind of a double-edged sword in that case, because again, we are stimulating the immune system. We're not trying to inhibit it with this particular drug. Okay, that's it for the derm section. Any questions on that? All right. Well, you guys already had your derm test. Did any of that stuff pop up on that test we covered here? Okay, good. So some of that will come up here as well. Again, I'm not going to get super specific on which one of these is super potent versus medium. Like you kind of have a good sense for that from the derm section you already covered, but it'll be more based on kind of principles like, why wouldn't you want to apply a super potent corticosteroid to the face, right? Why wouldn't you want to do that? See skin changes, but you also see what? Systemic absorption. You can see things with your glucose starting to rise up, infections, different things like that. So those are kind of the important concepts to remember as far as the different steroids we'll talk about. And again, when in doubt, what should you recommend as far as the steroid goes? Hydrocortisone is usually going to be pretty good for a lot of cases, right? Obviously, you might need something a little bit stronger, but for a lot of things, hydrocortisone is a good safe bet because, again, very limited side effects with that one. Moving on, we're going to start up with our ENT section here. Well, basically two sections on this, but they'll kind of bleed together a little bit. Okay, so we'll come back to antibiotics. Everyone remembers everything about antibiotics we already covered, right? Hopefully. So we'll talk a little bit about, and you'll see there's a lot of bleed over as far as the different bugs that are going to be causing infections in the upper respiratory tract. It's kind of where we're going to be focusing our talk on for this this section here. But first thing we'll talk about is acute otitis media. You guys have covered this already in your ENT section a little bit. Antibiotics are already used for it. So what would you recommend for an acute otitis? Yeah, amoxicillin is really a good one to start with. So we'll talk about that. We'll talk about some backups that you can use in case amoxicillin might not be appropriate. So in a lot of cases, these tend to be viral, right? So you want to make sure you have a really strong sense that this is going to be bacterial before you're going to be prescribing antibiotics. But if it is bacterial, three things you're going to be seeing here is going to include strep pneumo, H. influenza, and the more oxalic heterovirus. Those are your kind of most common ones. And depending on what their vaccination history is, you may lead you to think one versus another, depending on, do they have their H flu vaccine, that series is completed, things like that. And so you'll find that these trends will change over time as vaccines become more prominent. So the mainstay of therapy here is we want to go with high dose amoxicillin. So why do you think we want to use high dose amoxicillin versus say like just normal dose amoxicillin? Because usually if we're using like normal dosing, it'd be like 45, 50 milligrams per kilo per day, but here we're using 80 to 90. Why do you think that is? So yeah, so the ear can be difficult to penetrate, right? So it's difficult to get the antibiotic in kind of levels to actually get there. And then the other key part of that is Resistance, yeah. So resistant strep pneumo is becoming one of the biggest problems we're running into, is that you're having overuse of antibiotics, or people are undergoing multiple courses of antibiotics. So for instance, as someone comes in with recurrent acute otitis, like they're going to be more likely to have a resistant strep pneumo in those cases. And so you need higher doses. That way you're more assured that you're going to eradicate that infection with one go, right? Instead of using smaller doses and seeing how the patient does. Maybe they get better, maybe they don't. This is more likely to actually eradicate that and get rid of the infection there, okay? So that's one reason why we use higher doses, and this is one of those cases where you want to go back and make sure you're using indication-specific dosing in these cases to make sure that you're dosing appropriately based on the indication. Like lungs are going to be another area where we're going to use higher doses typically in order to make sure you can penetrate that tissue, because it can be a little bit more difficult. Now, if the patient is failing amoxicillin, so say you prescribe them a course of amoxicillin, usually 5 to 7 days or so, they come back and they are still having symptoms, what would you do at that point? You can change the antibiotic, and what would you step it up to next? Augmentin, right? So augmentin, now we're adding on what to that amoxicillin? Right, adding a beta-lactamase inhibitor at that point. This is going to help it to treat more resistant bugs. Also widens out that spectrum a little bit. Again, you're going to get a better coverage for especially those resistant diseases, or those resistant bugs, I should say. You can also use this for very severe disease. So they come in. They've had previous courses of antibiotics, you're more thinking a resistant bug, augmentin's probably a good thing to go with, or they failed therapy, augmentin's good, or if it's very, very severe and you really just want to knock it out, augmentin's a good one to go with, okay? Now, if they are unable to receive amoxicillin, we can switch it over and use something like ceftonir. And you guys remember what type of drug ceftonir is? Cephalosporin. What generation? Third generation, right? So that's important. So we're going with third generation, which again, we're getting better coverage. Again, still have some strep pneumo coverage, right? We're also getting better what kind of coverage as you go up in generations? Gram negative, right? So we're getting better gram negative coverage. So H flu, that Moraxella catarrhalis, those are things that are going to have better coverage as you get up there in generations. So ceftonir is a really good one to use for outpatient use. This is also nice because it has once daily dosing, which a lot of patients like, especially if you're trying to give this to kids and stuff. That can be very useful. Or we could use something like azithromycin. What type of drug was that? The macrolide. Good atypical coverage, that kind of with the macrolide. And so either one of these are fine for penicillin allergic patients, but again, always double check to make sure they have a true allergy. It's not something like diarrhea or they vomited or something like that. It's not really true blue allergy. Now, in some cases, you may find patients cannot tolerate oral medications, or if they have failed oral medications, say for instance, you tried amoxil, they failed that, you tried augmentin, they failed that. Now we need to step it up to using parenteral therapy, okay? Or if they're unable to take oral therapy, this is when you step it up to parenteral use, right? So you can use something like ceftriaxone, which is what type of antibiotic? Cephalosporin. What generation? Yeah, it's always important to think about what generation cephalosporin you're dealing with, and just kind of know your nomenclature like that. But yeah, this is another third generation. So what would be the benefit of ceftriaxone versus ceftonir? It's very similar coverage because, again, they're both third-generation cephalosporins. So typically, you're going to find that if something's resistant to ceftonir, it would be resistant to ceftriaxone too. The way it's delivered, absolutely. So we're giving this parenterally. We're giving this straight into the system, either intramuscularly or IV. You get higher levels, you're much more likely to really knock out that bug. And so this is one of the things where oral therapy fails. You got to switch them over to parenteral because you're more likely to get higher levels and you're more likely to get kind of sustained levels to really kill off those bacteria. Do you guys remember how often you're dosing ceftriaxone? Yeah, just remember Cetrax one time a day. That's usually what you're going to be dosing, unless it's like for meningitis or sepsis or something. You might do twice a day, but oftentimes you get away with Cetraxone just one time a day, which is nice. So what we'll have sometimes is patients coming in, they'll come back to the ER for 3 days straight, and so you usually get 3 days worth of Ceftriaxone, and that is usually enough to eradicate those infections as well. So that might be something you see every once in a while. It's not common that we do that because we don't like to have the patient come back for a new ER visit for 3 days in a row, but in some cases they may not be able to tolerate oral medications. That's just kind of what we have to do. So that's one thing you can do. Another option would be, if they cannot tolerate oral medications, is use something like benzathine penicillin G, which is what type of antibiotic? It's yeah, absolutely. So the penicillin, it's still pretty basic, but the nice thing with that bicillin is it comes in that kind of that lipid-based emulsion. Give one dose IM, levels stay high, long half-life. Is going to be able to treat that infection pretty well. Just one dose, which is a benefit there. Okay. So any questions on that, right? So know your kind of stepwise approach. If a patient failed amoxicillin, what do you go to next? Augmentin. If they had an allergy to amoxicillin, what should you go to next? Yeah, ceftonir, azithromycin. And some people will still feel very uncomfortable switching a patient from penicillin if they had an allergy over to ceftonir. But again, remember, what's the likelihood of having a cross reaction? Less than 1%, right? So you guys being kind of the new generation, a lot of new providers are going to come out without that stigma. A lot of older providers still have that. And I have to convince people all the time that, hey, this is totally fine. Give them a dose here in the ER. They don't have a reaction, they're good to go. Yeah, that sort of thing. Now, if you were to treat, say, like an acute bacterial rhinosinusitis, again, you're going to find the same bacteria here, and still an upper respiratory tract infection, very similar. Bugs you're going to be treating, very similar type of resistance patterns you're going to be running into. And again, this can be location specific. You may work in Orlando, find certain resistance patterns. You may go work in, say, Boulder, Colorado, and find very different patterns there. So it all can be dependent on where you're working. That's why you want to look at what those things that kind of give you an idea of what bacteria were, what strains were resistant or susceptible to an antibiotic. And antibiograms, right? So always consult your antibiogram. That'll give you a good idea what you're dealing with in a specific location. Some other things you may find come up here, Strep pyogenes, Staph aureus. These are more rare, but can possibly be under differential as far as bugs that are causative here. Again, in a lot of cases, you really need to decide between is this viral or bacterial. Typically, if the symptoms have been going on for more than 10 days or they have, say, worsening symptoms at 5 to 6 days, those are kind of key things you're going to look at to say whether or not this is more bacterial than viral. Because, again, I can probably give a lot of these patients, they're having 2 days of symptoms, 2-3 days. They come in, I give them antibiotics, and they spontaneously resolve. They probably would have done that anyway, right? So this is one of those things where you really want to make sure you're following your guidelines and make sure that they actually fit the criteria for having more likely to be having a bacterial infection. So notice here we kind of skip amoxicillin completely. We go straight to Augmentin due to, again, the high incidence of these beta-lactamases producing H. influenza. So again, if it's there in the sinuses, again, it can be a little bit more difficult to treat in those areas. Again, we just go with this kind of high dose amoxicillin, clavulanic acid, or Augmentin. Okay, so that's kind of one of the key differences here. Acute otitis media, you can use amoxicillin first. Here for rhinosinusitis, you got to go with the Augmentin first line. Okay. If they have a penicillin allergy, notice here we're going to be using either combination therapy or using an antibiotic that has much wider coverage than we would normally because of these either wider range of bacteria that can be causing disease or more resistant bugs. So in this case, you do something like clindamycin, which what type of spectra of coverage does clindamycin have? Anaerobes, absolutely. And what else? Gram-positives. Those are two big ones. Plus cefixime. You guys remember what that is? No. Yeah, another third generation cephalosporin. So that's one thing you can do as a combination there. And then, or you could use one drug and just use something like Levaquin, right? Yes, sir.
You had said that we should avoid third generation cephalosporins.
It depends on the situation, right? So if you can get away with using Augmentin, that's good to do. But in a lot of cases, you may have to switch over and use something like a third generation. So again, you like to hold off on those type of drugs as best you can. Like I would recommend holding off on Levaquin as best you can, right? Because that gets overused quite frequently, and we're seeing more and more resistance to it. So if you can use kind of the gold standard, something like Augmentin, you don't see as much resistance to that as you would some of these other stuff. You can use that kind of the gold standard to start with. Yeah. So again, either use a combination here, or you can just use a wider coverage with something like Levaquin. And you remember how Levaquin worked? The fluoroquine alone. DNA gyrates, that topoisomerase. You'll find it inhibits that, prevents that kind of unwinding, relaxing of the DNA strands, causes those more strand breaks and DNA damage. Then we're looking at acute pharyngitis. So again, mostly viruses here, but in most of the cases, if it's bacteria, we're going to find this is group A beta hemolytic strep. And so this is one of those nice things where we have rapid testing that we can do in most cases, especially like in ERs and whatnot. You can get a test very quickly that'll say whether or not they think your patient has group A strep or not. And then we can decide whether or not we want to treat antibiotics kind of right there at the time of the visit, which is nice, instead of doing a culture and coming back. We'll look at some problems with that and why we do backup cultures and things like that. You'll learn more about them. Or did you talk about that in ENT at all? How you'll do like a rapid strep test and then get a backup culture? Yeah. Okay, yeah. So again, a patient can be negative for that rapid strep, but still actually have strep, and that's why you do a backup culture. So that way you can call them up and be like, hey, actually you did grow this out. We're going to go ahead and prescribe you amoxicillin or whatever happens to be. But anyway, so again, group A strep is a big one we're worried about here. Now, we don't actually care about the actual bacterial infection because some people can just be carriers of this and not really cause any active disease. But we do want to prevent this acute rheumatic fever and some of these suppurative complications. So again, you can see significant heart damage that can happen after this, and so we want to prevent this from occurring in the first place. So what we will do, again, use that rapid strep test to prevent overprescribing. And again, we don't want to treat those viral infections, but we can utilize amoxicillin, and so this is one where we actually use a little bit higher dose, but you're just using one-time daily dosing, which is nice. So you just give amoxicillin 50 milligrams per kilo one time a day. Again, I'm not going to ask you dosing on the test, but again, first, second choices, things like that, I'm going to ask about. Amoxicillin, we'll do that for 10 days or so, and then that will go ahead and get rid of that infection there. Another option we can do is benzathine penicillin, use that bicillin there, because again, if they have strep pharyngitis, they're probably not going to be able to swallow very well, and so that can be a case where we want to use IM instead. If they did have a penicillin allergy, you can utilize something like Keflex. You guys remember what generation cephalosporin that is? First generation, so generally still be good for that group A strep. You don't see a ton of resistance develop with that. Clindamycin would be fine as well, or azithromycin. So if you can, stick with the beta-lactams, but if you need to branch out to something like Clinda or Zithro, you could do that as well. Okay. We also have some otic antibiotics that we can use. So this is better for like otitis externa. In a lot of cases, you're going to find that we'll use these in a lot of, especially for pediatrics. If you guys ever work in pediatric ENT, we do a lot of TNAs. We do a lot of myringotomies and put tubes in to the ears, and so we'll use a lot of prophylactic antibiotics for those kids as well. Because again, as soon as you're putting tubes into the ear, you're kind of giving bacteria a site for entry, essentially, to cause an acute otitis. So basically what you're going to see here is that when you have really this like inflamed ear canal, like it's very, very painful, it can be very uncomfortable for the patient. And so what we typically are going to do is usually use a mix of anti-infectives, so use an antibiotic plus a glucocorticoid, right, as an anti-inflammatory. So that's why if you ever see a combination like dexamethasone plus ofloxacin or ciprofloxacin, we'll look at the antibiotics in a second, but usually there's a glucocorticoid mixed in there. So that way we're inhibiting bacterial growth. And again, the nice thing about using otic antibiotics or applying directly into the ear is, what do you think the concentrations are versus if I were to give, like, say, a pill? Super high, right? Because you're just treating very, very locally, so you get very high concentrations there, and so you're unlikely to see resistance develop, which is nice. And then you can also inhibit that bacterial growth. You don't really have to worry about that anti-inflammatory effect of the glucocorticoids kind of preventing the antibiotic from working there. So things we'll use is either something like ciprofloxacin, which we mentioned is what type of drug? Yeah, it's fluoroquinolone, right? We might use a combination of ciprofloxacin plus dexamethasone. We'll talk about that in a little bit later, but that would be a glucocorticoid that we use very commonly for ENT stuff. Some cases you're going to use neomycin, polymyxin B, and hydrocortisone. So I talked about polymyxin. You guys remember how that works? Kind of punches a hole right through the bacterial cell wall and to damage it, right? This is one of those things we don't like to use systemically because a lot of neuro and ototoxicity, but we'll use it topically very frequently. So like Neosporin, you're going to find polymyxin B in there. You'll also find neomycin. That is actually an aminoglycoside very similar to like amikacin or gentamicin or something like that. And then hydrocortisone obviously is going to be a glucocorticoid for the anti-inflammatory effects. That's called cortisporin. And then ofloxacin is another one we may use occasionally, right? That's just the racemic mixture that levofloxacin comes from, right? So what might lead you to choose one versus another? Okay, so tympanic membrane perforation, right? So why would that matter? You don't want to use neomycin because what could happen? So we'll talk about that in a second. The neomycin is more likely to cause dermatitis. So if someone has an allergy to it, the neomycin is the most likely one to have a reaction to that. The polymyxin I mentioned, sorry if I misspoke when you guys answered. The polymyxin B, though, if that gets into the ear, if it goes past the tympanic membrane, what can that affect? The hearing, right? So it can affect the hair cells just like it would if I were to give it IV, right? So normally the tympanic membranes is a impermeable enough barrier that if that's intact, I can go ahead and give something like polymyxin B, but if that's ruptured, I cannot give that drug at that point, okay? So that's why it's important to make sure you're evaluating your patient well. If you can't tell, then go ahead and avoid that one. But this is a good cheap one you can use. Oftentimes things like Ciprodex becomes very, very expensive, and that may preclude you from using that drug for a lot of your patients if their insurance does not cover it. That's one of the biggest problems we run into is after our ENT docs put tubes in, getting their appropriate post-surgical coverage, it can be difficult because their insurance may not cover something like Ciprodex, which is kind of one of our go-to. So is there any way you think you can get around using a really expensive combination product like this? Use eye drops, absolutely, yeah. So we can use eye drops and put them into the ear, and that actually can be a much cheaper option. So at that point, they're given 2 drops. So we can use like ofloxacin plus we'll give ophthalmic drops into the ear, and that way they get the combination benefit. They're given 2 drops instead of 1, but it's going to be a lot cheaper for your patients, which that's one of the things we'll do to make sure they get the drugs they need. So could I do the opposite? Could I give an otic drug and give it ophthalmically? No. Never can do that. You can go from eye to ear, never from ear to eye, because it's not formulated for the eye. When you're giving something ophthalmically, which we'll talk about and when we get to ophtho, is it has to be pH balanced, it has to have the right tonicity, it has to have a lot of things with it that make it so it does not burn the heck out of your eye when you put it in, right? Ophthalmic to ear, totally okay though. So again, you can use for otitis media, externa. Again, notice the neomycin is more likely to cause sensitivity. Polymyxin not going to be good for patients with ruptured TM or if they have tubes in place. That's the other thing, because again, that just gives an entryway for the polymyxin to actually get in there, cause cochlear damage. And then Ciprodex, very expensive, but we can use Oflox plus dexamethasone ophthalmic. So basically just what we said. Okay, so a couple of ENT antifungal things. Ketoconazole is a common antifungal we're going to use. Again, you'll find this one being used orally. Now, notice it's not something like Nystatin where you can get, it's good for kind of like thrush. It doesn't really get absorbed systemically. This one can be used systemically because it will be absorbed. Again, this is going to be working by inhibiting that fungal CYP P450. You will see that it will affect our P450 as well. So you have to worry about drug interactions, especially like 3A4 interactions, things like that. And then also with the azoles, one thing you can run into is QTC prolongation, right? And we said QTC prolongation happens because of what? You're blocking ventricular repolarization by blocking what channel? Potassium efflux, right? So again, we have to send out potassium out of the cardiac cell in order to get it repolarized for the next beat to occur, or next action potential to occur. So by blocking potassium efflux, you prolong that repolarization, more likely to have arrhythmia. Okay. Usually patients are going to be on this for a short enough period of time that you don't have to worry about all these other effects happening, but you can see potentially some hepatotoxicity, but it's pretty rare for the most part. Again, just know that 3A4 inhibitor is going to affect a ton of drugs. You need to screen your patients before prescribing this. And so you'll find that it has lots of contraindications depending on what other drugs they happen to be on. So for instance, a lot of drugs here are going to be all metabolized by CYP3A4, namely things like simvastatin. Does anyone know what we use that for? Yeah, it's a cholesterol medication. If you add these two together, you're more likely to see things like hepatic damage. You can see muscle breakdown, called rhabdomyolysis. You can see lots of problems that develop from that. So again, just check your list before prescribing. Make sure that they have an up-to-date medication list, because one of the number one medical errors that you can see is patients do not get a good med reconciliation, or their med list changes and you're not aware of it. You prescribe something that interacts. And so that's a very, very common error that we'll run into. Nystatin I mentioned is nice because it's non-absorbable, antifungal. It's working by binding the sterols and then the cell membrane, increasing that cell wall permeability. Again, oral candidiasis is probably the most common thing we'll use that for from an ENT standpoint. So either they already have established thrush, or if we're trying to give it as a prophylactic if they happen to be immunocompromised. Usually it's either like a swish and spit or a swish and swallow kind of thing. Depending on your patient, they may not be able to really coordinate very well. So if it's swish and swallow, that's totally fine as well. But you may see different instructions depending on who you're dealing with. Okay, and then a few systemic antivirals you may run into very commonly. So we kind of mentioned already, we talked about Acyclovir. We're going to go a little bit more into detail on these here. Just know there's several different ways that antivirals can work. We mentioned specifically we're talking about inhibiting DNA and RNA synthesis. This is going to be the main one we're going to be talking about here, but just know there's going to be lots of other ways that drugs can affect these. This will come up more in Pharm 2 when we talk about HIV, when we talk about hepatitis, things like that. So we'll cover some different mechanisms there, but just know that inhibiting the DNA synthesis is one of the big ones we're going to talk about today. So again, herpes virus is going to be one of the more common viruses that we actually have drugs for, because again, there's lots of viral infections we don't really give anything for. Influenza is one because we have a drug that can treat that, and herpes might be the other most common one you'll treat. Again, type 1 you see going to be more kind of upper body on the mouth and face. Type 2 is going to be more genital infections and things like that. Again, very similar drugs you're going to use for either one in either case. Potentially you can run into varicella zoster and then cytomegalovirus. Who do you see, what type of patients get cytomegalovirus? Yeah, immunocompromised patients. So usually HIV/AIDS patients, they have very severe deficiency in CD4 count. Sometimes those cancer patients. Yeah, those are the big ones that get CMV. If you're a really chronic alcoholic, you don't have, certainly your immune system takes a hit. I'm not sure specifically if they happen to be one of the groups that gets that more likely. That could be true, but I just don't know off the top of my head. We can run an experiment though as part of epibiostats and make half of you guys alcoholics and half you not, and then see what the instance.
Someone that was like a really, really, really heavy drinker.
Yeah.
And they got this.
Could be, yeah, because I mean, certainly chronic alcohol use can suppress your immune system, especially if they get malnourished, because a lot of those alcoholics, they tend to get most of their calories from alcohol and not from actual food sources. So yeah, there's kind of a host of problems that they can be, yeah, at risk for. So. Anyway, so again, these antivirals are guanine analogs. So again, these are going to be inhibiting guanine incorporation to DNA. We'll look at more of that in a second. Again, you don't need to be able to draw these out by any means, but I just kind of point these out, and so that way you can note some of the similarities in structure between these. And what we actually find, and you guys remember that term prodrug that we used? What's a prodrug? Has to be activated, right? So we give the inactive form, we get to activate, and that usually leads us to have higher bioavailability for a lot of these drugs. So when you see things like Valacyclovir, that gets converted over into Acyclovir. Valganciclovir gets converted over to Ganciclovir. So you can see kind of that structure that is lying within there, just cleaving off part of it within the liver. Famciclovir and Penciclovir similarly have that relationship. So again, the ones on the right side here are prodrugs that get converted into the actual active compound. So we'll talk about Acyclovir. Zovirax is a common brand name for that, and Valacyclovir or Valtrex. I'm sure most people grew up seeing those commercials, right? Maybe? No? Man, I'm aging myself out pretty bad. Anyway, so what we find is these are guanine analogs, and basically they're lacking that sugar moiety, so when they get incorporated into the DNA, there's no further elongation that can happen because they're missing that sugar moiety there. And again, also they're going to be selectively phosphorylated by a viral thymidine kinase, and then by getting selectively picked out versus the actual normal guanine being formed, it'll get incorporated into the DNA, and then you can't have any further elongation. That eventually leads to replication errors, further damage done, and that leads to viral cell death. Not cell death, but viral death. So we can give these most often for herpes simplex and also occasionally for varicella zoster. Again, so if you ever have someone who's like shingles or something, this is oftentimes one of the group of drugs that will be prescribed. You can find resistance actually forms because they can actually have the virus start to modify its thymidine kinase. So if it doesn't get phosphorylated, it never actually gets incorporated into the DNA in the first place. So you can see resistance does develop to these eventually. But again, looking at the bioavailability, or again, that percentage of drug that actually makes it to the systemic circulation, Acyclovir is pretty poor, about 22%. But if you give it as a prodrug, this Valacyclovir, you get about 70%. So that's kind of one of the big reasons why we do that, in order to get smaller doses that we're giving in order to get into the system at higher concentrations, essentially. Okay, so you can see a lot of side effects when given these systemically. So some of the big things to note is you really want to make sure your patients are maintaining good hydration, because one of the things you can see is that patients who are dehydrated, they have a higher tendency to crystallize out this Acyclovir in the kidneys, and that can lead to renal damage, right? So this is why we say make sure you're drinking lots of water. You want to stay hydrated, keep the kidneys flushing this stuff through in order to prevent this crystallization that happens there. And so one of the other big things you can see potentially is also some CNS issues that pop up. So potentially seizures can happen. Again, this is a renally eliminated drug, so you need to watch for renal function and make sure you're adjusting for that. But if the levels start to climb up, you can see seizures, delirium, tremor, things like that can start to pop up. So just be aware of that. And also one of the big things to note here, that usually with antivirals, you want to give it sooner than later. The sooner you can give it, especially within 24 hours or so of symptom onset, the more likely you are to actually have efficacy. At a certain point, you're going to find that the efficacy diminishes pretty dramatically after that first 24 to 48 hours. And so here we'll see things like Acyclovir if given within the first 24 hours. It can shorten the actual acute illness, but it doesn't actually cure the infection in a lot of cases. So again, we use this more for kind of outbreaks for these diseases, especially like for herpes and things like that. Not going to cure you, unfortunately, but it can help to kind of shorten the duration of symptoms and hopefully shorten that period where actually shedding viral particles.
Can topical Acyclovir stop the progression of shingles?
It can help with the flare-ups. It doesn't necessarily, yeah, it's not going to necessarily reverse what's already there necessarily. I'd have to look more into that, though. Hard to say. Yeah. Probenecid, actually, not to worry about that. This is actually an old school drug we used to give. We don't use it clinically anymore. Basically, what you saw is that back in the day, penicillin used to be really hard to make and used to be very expensive, and so we wanted to keep it in the system for as long as possible. We mentioned because penicillins and other beta-lactams, are they concentration or time-dependent killers? They're time dependent, right? Because we want to keep their levels up as long as we can. So we used to give probenecid. It would actually prevent renal excretion. Because you guys remember the kidneys, how they can reabsorb things, they can excrete things into the renal tubule. Probenecid actually block the excretion. So you'd have higher levels of penicillin sticking around. It only affects certain drugs. But if a patient happened to be on probenecid, when we talk about gout, this drug will come up again because it actually prevents excretion of uric acid crystals. But you'll see it pop up there. But again, clinically, we don't use it very, very commonly. Okay, looking at Famciclovir and Penciclovir, again, Famciclovir is going to be the prodrug there. So if your Penciclovir bioavailability is too low, they say, hey, I got you, Famciclovir. So you guys got that one, but not the, okay. So again, you use this a lot for herpes simplex, varicella zoster. Again, you'll find they have similar spectrum of activity here, and very similar actions and toxicity. So we kind of mentioned these. Acyclovir is probably the first go-to drug. It's probably the more common one you're going to see prescribed. Valacyclovir as well, if they can afford it. Usually Acyclovir is a little bit cheaper, but these might be used as backups, especially if you start to have resistance start to pop up. You can use these as a backup. Penciclovir usually gets given IV because the bioavailability is so poor, but Famciclovir you can give as a prodrug because it has a lot higher bioavailability. It's going to be more able to get high enough concentration systemically when you give it orally there. And again, these are going to be for patients who are maybe having more systemic viral infections, so especially if you get like a herpes simplex, like encephalitis or something like that, where they're actually having CNS involvement. This is where you're going to switch over to start using more IV therapy, and so that can be make sure you get the high enough levels to really penetrate those tissues there. And then Valganciclovir and Ganciclovir, again, similar mechanism of action, similar toxicities. Yes, ma'am.
Sorry, I don't know if you said this, but what is the point of using a prodrug? Like, what is the point of it being inactive out of your body?
So it's inactive out of the body, gets absorbed through the GI tract. First organ it hits is the liver. Then it gets activated there. So instead of the active drug going to the liver, being broken down, and then getting absorbed, you give the prodrug. So it's kind of like giving it like it's like a Trojan horse almost, right? So you're sneaking in the drug. Liver is like, okay, I'm going to chew this up, and then all of a sudden the active drug's there, and they can march off into the systemic circulation. So think about it like that. Okay, I'll probably use that from like here on out into eternity. That's a good analogy. Okay. So this is kind of more hardcore, especially kind of IV use only antivirals. You see this a lot like in cytomegalovirus for patients who are transplant patients, because again, in order to prevent rejection of an organ, what do we have to give you? Anti-inflammatories, immunosuppressants, right? Because we want to prevent rejection happening there. So those patients as well are much more susceptible to some of these kind of opportunistic viral infections. So CMV, herpes simplex, varicella, all those things. That's why you'll find that, especially when you get to talking about transplant stuff, that vaccines are super important for those patients to make sure that they can get a good immune system and have good immunity against some of that stuff. Anyway, again, bioavailability is going to be a little bit better with Valganciclovir, but again, these are usually reserved for those, especially CMV. That's where we kind of hold this off for that. Now, you'll notice that we mentioned it inhibits guanine incorporation into DNA, and it would be nice if it was 100% specific for the viral DNA, but unfortunately there's a little bit of bleed over, and so you can find this will actually affect some of our human cells. And again, you'll find that these things that affect DNA, especially with replication, is going to affect those that are most rapidly dividing. And so what type of cells are most rapidly dividing in the body? Skin cells, hair cells, GI cells, white blood cells, right? So white blood cells, things that are getting produced through the hematologic kind of that pathway, you're going to find those take a hit as well. So thrombocytopenia, neutropenia, this is why you can see that. And again, some of these patients are already immunocompromised to begin with. Now you're making them even more neutropenic, right? So that is one risk you worry about with these drugs. The risk is still present with things like acyclovir. It's just a lot lower for the most part, but it's something you want to monitor for. But again, also see CNS effects. And again, it's one of those things where, if you're treating a patient who's having, say, like, herpes encephalitis and already having ultramental status, and then all of a sudden they're given one of these drugs, are they getting worse because their infection is getting worse, or is it because now the drug's causing some ultramental status as well? So sometimes one of those things we need to be aware of the side effects to make sure you can kind of key in and see, like, okay, well, maybe it's this, maybe it's that, and you can kind of keep the differential open there. But again, a lot of patients end up having to stop treatment due to these side effects that are happening. Phosphornet, just kind of mentioned this briefly. Again, this is one that we will use for really resistant viral infections. The one time I've seen this used was for a transplant patient. Had a bone marrow transplant, essentially, because they had really resistant cancer. She was on all sorts of immunosuppressants and getting a really bad herpes CNS infection. I mean, like, just looking at the CT scan over time, it looked like moth had like just kind of picked out parts of the brain. It was so destructive. And so we actually ended up using this Phosphornet because she had really resistant herpes that we were trying to treat. Acyclovir didn't work, Ganciclovir wasn't working, so we ended up using this kind of backup. And again, a lot of toxicity with it, especially things like nephrotoxicity. You can find a lot of electrolyte abnormalities happening with this one because it can chelate ions like calcium or magnesium, and basically causes such toxicity. We really reserve that from when other drugs have already become resistant to whatever virus you're treating there. You get lots of side effects associated with it, so just be aware this is one you may see very occasionally, but not too often. Okay, so any questions on kind of the anti-infective side of ENT? All right, moving on. Breezy. So we're going to talk about anti-inflammatories, and basically, if you have a cough or cold, like what kind of the OTC stuff so we'll cover a lot of OTC stuff. We'll talk a lot about corticosteroids here, so we'll cover this, and this will be a little bit easier than a lot of the antibiotic stuff. Okay, so first off, anti-inflammatories. So basically, the first one we ended up having was salicylates, right? So aspirin, methylsalicylate, acetylsalicylic acid, kind of all within the same category. And you guys know what aspirin, with the kind of the shortened form of it is? ASA, right? So and that comes from that acetylsalicylic acid. So that's why it's ASA there. And do you guys know what tree this came from? Yeah, the willow tree. Yeah, so this is actually, again, a good source for natural products becoming drugs that we use very commonly. So anyway, so salicylates, good oral absorption. It's actually one of the few things you'll actually see get absorbed from the stomach rather than the small intestine. So that's why it's important when we talk about gastric acidity and things like that, how good the absorption is going to be there. Basically, what you find with these anti-inflammatories, and so these are going to be considered your non-steroidal anti-inflammatory drugs. So aspirin still falls into that category of a non-steroidal anti-inflammatory drug because, again, it's not a steroid, right? And so you're going to see that it's going to be an irreversible, non-competitive blocker of the cyclooxygenase. Okay, this is going to be non-selective, so it's going to affect, there's several COX enzymes that are out there, so cyclooxygenase 1 and 2, which are the primary ones we're going to be dealing with. There's also COX-3, which is like sometimes found in the CNS, but clinically is not really relevant to our purposes here. But the big thing to note here is irreversible. So that means that once it binds up to cyclooxygenase, until that cyclooxygenase gets broken down and a new COX is formed, you're not going to find any activity of that enzyme. Okay, so that's going to be important to kind of distinguish the activities of aspirin versus your other non-steroidal drugs and their activity. So as you might imagine, what do you think the duration of action of a drug like this is going to be versus something that's, say, reversible? It's going to be longer, right? So you're going to see the effects of this drug stick around for longer than you would if it was a reversible inhibitor. You guys remember what cyclooxygenase actually does? Yeah, it works to form prostaglandins, right? So again, you remember that arachidonic acid pathway. I think I have a slide of that later that we'll see. But basically, you start off with phospholipids coming from the cell membrane. You're eventually going to have arachidonic acid being formed, and that gets there's kind of two pathways. There's a leukotriene pathway, and then you also have the cyclooxygenase pathway. And this is where a lot of things like prostacyclins and thromboxanes and other prostaglandins get formed from this pathway. And you're going to kind of find that there's kind of two main varieties. There's COX-1 and COX-2. Does anyone know what the difference between these two are? So, two terms here. There's going to be constitutive, and there's going to be inducible. Okay, so inducible, what do you think that means? You can make it happen, right? So I can, so for instance, if I sprain my ankle, I'm going to have acute inflammation in the ankle. I'm going to induce cyclooxygenase 2, right? So cyclooxygenase 2 is the inducible version of the enzyme. When you have an acute inflammatory reaction somewhere, cyclooxygenase 2 is usually the one that gets activated there, right? Versus a constitutive enzyme, what do you think that means? Happens all the time, so it's always present, right? So COX-1 is the constitutive enzyme. It's always going to be present. It's always active, and this is really important for things like gastric protection, right? So this is we will see that some of those prostaglandins are really important for helping to maintain that mucosal barrier. You guys remember that when we covered that in GI in physio? Right? You need prostaglandins for that to happen. If you lose that, you end up having ulcers that can form because you lose that barrier. The gastric acid can break through the stomach lining. It's no good, right? So that's why one of the big side effects we're going to see with these Non-steroidal drugs, they can cause GI damage, right? You can see duodenal ulcers and gastric ulcers that can form from this due to the fact that they can have an inhibitory effect on that gastric protective barrier, right? So COX-1 is always going to be expressed, it's constitutive, it's always present, and so that's why that'll be important when we're talking about COX-1 non-selective versus COX-2 inhibitors, and we'll talk about that a little bit later when we get to some of our other non-steroidal drugs. Anyway, big thing here, salicylates are going to be irreversible. So once they bind to that enzyme is basically non-functional until it gets degraded down and a new one gets produced. Okay, and this is important because this actually has effects on platelets, right? So we give aspirin to what type of patients? Yeah, heart patients, right? Cardiac patients, because we want to prevent what from happening? Blood clots, right? Because clots will happen where? Those patients? Not the valves necessarily. Yeah, in the coronary arteries, and then if you have a big enough blockage due to clotting, what happens? And then they die, right? So you don't want that to happen. So what we do is use antiplatelet drugs to prevent those clots from forming in the first place, especially when you have like those plaques and things that are forming. They love to attract platelets. You give an antiplatelet drug, and so normally you guys know like the dose that we'll give to a patient every single day for those like cardiac patients. 81 milligrams. Is that like a really big dose or a small dose? It's a little baby dose, right? It's a baby aspirin. That's why I call it that, But you can give it to adult patients because of the fact that it's irreversible. Basically, all you need is that 81 milligrams a day continuously given to inhibit all that cyclooxygenase in the platelets, right? So you don't need big doses to do that because they're irreversible. Those effects will stick around even longer than when the drug actually gets metabolized off and eliminated, right? So that's one of the reasons why we can use baby aspirin every day for those patients because it works very well at blocking all the platelets there, right? So after a couple of days, you basically have levels build up enough where all the platelet cyclooxygenase is blocked for its activity there, right? And so then you basically have to have functional platelets again, you got to make new platelets essentially, right? So that's one of the things you're going to see there. As soon as platelets get inhibited, they're done until because platelets themselves, they don't really have the capability to produce new cyclooxygenase when you have a nucleus, right? So that's why it takes time. They have to get degraded and then you produce new platelets, and now you have more platelets that are able to bind. Make sense? Okay. So anyway, so again, salicylates, you can see there's several different effects that can happen here. So I like this table a little bit. I take it from some of my tox stuff because it's good to look at the side effects you can see here. And a lot of it is related back to the dose that you have. And so early kind of, smaller doses, so say like 81 milligrams, so the dosage here is in grams, up to like 325. Usually you think dosage of aspirin, anywhere between 325 milligrams, maybe up to a gram. Potentially that's usually a therapeutic dose. You get antiplatelet effects, and so one of the complications of blocking your platelets is what? Bleeding, bruising, right? So that's one of the risks you run into, especially if a patient's on aspirin plus an anticoagulant like warfarin or something like that. It's one of the risks you run into there, right? So again, that effect is going to be there well after they stop taking the aspirin until they actually have time to recycle all those platelets. So once you get to higher doses, this is where we're going to get into antipyretic effects, which antipyretic means what? It's going to deal with fever, and then we also have the analgesic effects. Those are going to be good for pain relief there. Notice you still have that bleeding risk there. You're also more likely to see some GI upset, so that's one of the common side effects from the salicylates. Also, if you have a hypersensitivity, that's one thing you're going to note there as well. And then as you get in higher doses, you're seeing more anti-inflammatory effects. Also, this tinnitus there. And so again, it doesn't have to necessarily be ringing in the ear specifically, but it could just be kind of muffled hearing as well. I actually had it's kind of unfortunate story. I had a friend who was, unbeknownst to me, is actually depressed, and this is actually when I was doing my fellowship in tox, and he called me up, and he was actually doing a project on salicylates. He's like, hey, how long does it take for salicylate poisoning to actually kick in? And I was like, oh, it takes this long. You should see these effects, blah, blah, blah. And then sure enough, like the next day, I realized that he's in the hospital for that. And I was like, oh, boy, that was weird. But anyway, one of the things he noticed, he did fine, though. He survived, and he's doing very well nowadays, so that's good. But anyway, don't call up your tox friend if you're trying to kill yourself. It's just not a good thing to do to them. Anyway, but one of the first things he noticed was that he had a very muffled kind of hearing, and so that's some people will see that even at therapeutic doses. So they take say 500 milligrams, they can have some of that ringing or that kind of muffledness. That can be one of the first signs you see there. As you get into higher doses, you start to get what we call salicism, which is kind of the tox picture that you see with that. They get a lot of hyperventilation. You find that aspirin will actually stimulate the respiratory drive for the patients. They oftentimes come into tachypneic, breathing off a lot of CO2, so they typically have a respiratory alkalosis that happens because of that, and then eventually they can develop this kind of really catastrophic metabolic acidosis. Aspirin is definitely no drug to joke around with, and really important to make sure that patients are not overdoing it when they're taking this. We had one patient who, you guys are familiar with like Goodies powders or BC powders? What are those? Yeah, the anti-pain. How do they? What's the dosage form when they come in? Yeah, so it comes in a little powder. It comes in these little kind of wax paper sachets, essentially. It's the pharmaceutical term for it. But you just put it in your drink, it dissolves, and you just drink that. And we had one guy who would take that every single time. He didn't know it was aspirin. It's kind of this kind of back of the woods, Duval County resident, typical Duval County guy. And every time he had chest pain, he said, "Oh, I want to take a goodies." And so he took a goodies, and he'd take this like several times a day. And then finally he's like, "Well, this isn't working. I'm gonna call it EMS." EMS comes over and they say, "Hey, have you taken any aspirin today?" He's like, "Nope." EMS gives him aspirin, and he gets into the hospital, and the ER resident was like, "Oh, have you had any aspirin today?" He's like, "Nope," and sure enough, he gets another dose. So we end up kind of making him a little more toxic than he should have been because of that. But be aware, patients in the South, they like these goodies and BC powders as like just general headache stuff, but those do contain aspirin, so be aware of that. I find some people up north don't really see a whole lot. It seems to be more of kind of a southern kind of thing. Okay, so contraindications. They have a bleeding disorder. They are more likely to have bleeding and bruising based on this. We don't use this very often in pregnancy, and we'll see just a little bit later. We don't like non-steroidal drugs in pregnancy for a couple reasons. We'll look at why that is. But actually, they found some studies that very low doses might actually help with hypertension associated with pregnancy and preeclampsia, things like that. But the other big thing you want to know is children who have a fever associated with viral disease. So if they have the chickenpox or influenza, you do not want to give little kids aspirin. So usually I say less than 16. I do not recommend aspirin for fever related to a viral illness. And that's because they're at risk for what we call Ray's syndrome. So anyone ever heard of that? Yeah, so Ray's syndrome is potentially a deadly condition, complication of using aspirin for these. So otherwise known as kind of fatty liver encephalopathy. That happens, again, children less than 15 are at risk for this. About a 50% mortality if not caught kind of early and treated pretty aggressively. See a lot of vomitings, progressive CNS damage, and they end up developing a lot of hepatic injury. It's kind of fatty liver that develops with that. So just know that's why we recommend against using aspirin for those patients. It just happened to be at an increased risk during that. You'll see there's several stages to it, and there's actually a lot of literature out there and a lot of like new kind of advertisements and things like that to try to prevent people from giving aspirin. Because if you're a parent and you didn't know any better, like you think, hey, I take aspirin for my fevers, like, and why can't I give it to my kid? And so fortunately we have a lot of things out there that are trying to educate people about Ray's syndrome. Also note things like Pepto-Bismol. Does anyone know what the generic name for Pepto-Bismol is? It's bismuth. There's salicylate in there. So actually, Pepto-Bismol has salicylates in it, and so that is one of those things where a lot of people don't realize, especially if they're having some gastroenteritis or something like that, they don't realize that they're actually having salicylate products being given to their children. So that's another thing we recommend avoiding for those patients. Again, I'm not going to ask you on specific stages, but again, if I were to say which one of these patients would be contraindicated from receiving aspirin, and I say a 9-year-old kid who just got over the chickenpox, I would say, hey, not for this kid, right? So that would be the contraindication there. Okay. So again, just general patient information. Obviously, if their fever is over 100, it's usually when we make the recommendation to go ahead and give it to those patients. Obviously, if they need to drink plenty of fluids because if they're febrile, they typically are having a lot of extra insensible losses of fluid. So again, hydration is really important for those patients. And then typically, if things are not getting worse, or if they're getting worse or they're not getting any better, that's when you usually recommend they come in. So again, always educate patients when they're self-treating for these kind of things. Like, hey, when are the signs and symptoms that I need to come in, or what time frame should I be coming in these cases? And we do not recommend combining aspirin with other NSAIDs because you will find those effects are cumulative. You will find extra risk for things like bleeding, bruising, GI toxicity. So again, think of aspirin in the same category as an NSAID, like ibuprofen or naproxen, which we'll talk about in just a few minutes. But they're in the same kind of categories. So you don't want to mix those two together. Okay. Again, be aware the interaction between anticoagulants and the aspirin effect. Okay. Any questions from the first half? All right, so I know this is a drug you're commonly having to take, especially around 8 o'clock in the morning, back before Irma, because mostly my lectures were during that time. I didn't understand that. But so now we're going to go into other non-steroidal drugs, non-steroidal anti-inflammatory drugs. And so one of the big ones we'll run into is going to be ibuprofen, otherwise known as Motrin. So I kind of mentioned a couple of these. There's other NSAIDs that are out there than just what's here. I'm just kind of talking about kind of easy over-the-counter sort of antipyretics, analgesics you're going to run into kind of most commonly. When we get to the rheumatology section, probably in Pharm 2, we'll kind of cover all the NSAIDs kind of in their full spectrum. I just kind of wanted to mention the more common ones, that especially ones patients will probably be self-medicating with, or the ones you'll be recommending to them to buy. So again, ibuprofen over the counter, it falls into that non-steroidal anti-inflammatory drug pathway. So we can use this as an anti-inflammatory, as an analgesic, and also as an antipyretic, right? So it'll work for fever as well. And again, same mechanism you're going to find for aspirin. The only difference is this is going to be a reversible inhibitor of cyclooxygenase 1, 2, and again 3 is there as well, but 1 and 2 are the big ones we worry about clinically. So you decrease prostaglandin synthesis, you decrease that inflammation's happening there. So it can fix your headache, or it can fix your fever, or whatever it happens to be. But note that once the drug is out of the system, you don't have any of those effects that are sticking around, right? So the drug's only good while it's around. Otherwise, the cyclooxygenase is going to, once it gets dissociated from the drug, it's going to start working again, right? So you can see, say, increased bleeding effects while they're on the drug, but if they stop taking it, the bleeding effects go away, essentially, right? So you don't really run into nearly as much clinical bruising and bleeding as you do with aspirin, because those effects stick around for a lot longer, for the lifetime of those platelets, essentially. But again, use this for kind of more mild to moderate pain. And as far as pregnancy category goes, it kind of changes. So we haven't talked super in depth about pregnancy category just yet. But does anyone know the different pregnancy categories? A, B, C, D, and then what's the fifth one? X, actually. I tricked some of you. Right, so basically, we're kind of moving away from pregnancy categories. We'll talk about that later and why we're moving away from those. They're not super useful, but essentially, A are things that you can give with impunity because it causes no harm to the fetus whatsoever. Again, it's going to be kind of informing you about the teratogenicity of a drug, saying what kind of fetal damage you can have happen there. B is also pretty good. C is kind of like a big shrug, like we don't know what's going to happen because we don't have good studies. Because again, how easy is it to do studies in pregnant women? Not at all, right? Because they're a protected class. You can't really do ethical studies in pregnant women and what kind of effects you're having on a fetus. So again, C is going to be kind of one of those things we don't really know. D is going to be there is documented harm, but there are going to be some cases where the benefits outweigh the risk, essentially. Because again, if the mom dies from a medical condition, fetus is going to die as well. But there could be some cases where you want to give it in order for maternal survival, even though there may be damage to the fetus, right? So that's one of those things you may do rarely. And then X is absolutely contraindicated. Do you guys know of any category X drugs we talked about recently? Accutane, yeah, isotretinoin is a category X. There's no reason, as much as I would like pregnant women to have nice clear faces, there's really no risk for them having acne or in a long-term standpoint, right? It may have some psychological damage if it's really bad, I guess. But if you're pregnant, you should probably be more concerned with that. So anywho, all right, so category X, some of these drugs can actually change based on a trimester the mother's in, because we'll find that there are different kind of physiologic effects that occur through time. And so basically you're going to find that, especially in the third trimester, ibuprofen ends up being a category D drug, which means there's very rare instances where you actually want to use it. Does anyone know why that is? So there is the, in the fetus, there is the ductus arteriosus. Are you guys familiar with that? Right, so ductus arteriosus allows for mixing of the fetal blood, because again, when you guys cover fetal blood flow, you know it's very, very different from what actual adult blood flow is. And so you need to have that open. If you close it prematurely, you're going to have poor circulation of maternal oxygenated blood to the fetus, right? So you want to keep that open while the fetus is relying on that maternal blood flow. But then as soon as the baby comes out, then you want it to close up, and which it does naturally on its own. Normally prostaglandins keep that open for the fetus. There's high enough levels circulating around that keep that open. But if you were to give the mother an NSAID like this, you could actually decrease those levels and cause it to close prematurely. So that's why they say, hey, third trimester, we don't like to use that. There's probably enough safety to think, hey, we can give it earlier than that. But when we talk about drugs in pregnancy, we're going to find that there's another safer drug, which we'll talk about in just a minute here. Okay, so just be aware there's pregnancy categories that can change. Know that that's why we would avoid that in that kind of late stage pregnancy. Now, if a baby is born and they do not close that PDA on their own, do you know what we give them to close it? We actually give them IV ibuprofen. So we actually can use this drug, even though it's a danger while the fetus is still in the mom. Once it's born, you can actually use this to close it on their, as a chemical means of closing it, rather than having to do like a surgical ligation or something. So, anywho, right, so we're going to be dosing this drug. Normally the pills come in a 200 milligram dosage form. Again, usually you'd say, hey, take 1 to 2. Usually you can do it, say, every 6 to 8 hours or so is usually kind of how frequently we would dose it. Try not to go too much more frequently than that, more than every 6 hours or so, because you do run the risk of things like GI side effects and whatnot. And you don't really get a much more bang for your buck if you increase the frequency any more than that. Does anyone know the dosage form for like the prescription grade ibuprofen is? It's like 800, yeah. So 800 is kind of the maximum like single dose you'd probably ever want to give to a patient. So like normally, like, you know, I try to stick it to the medical field because when I take over the counter ibuprofen, I just do 4 at a time. Like whatever, no big deal. Yeah, so again, you know, if your patients are still having pain, they're taking 400 and it's not working, you can have them recommend more than that. Again, it's probably cheaper to buy one of those 55-gallon drums from Costco of ibuprofen than have them get a prescription. So again, because we are inhibiting the prostaglandin synthesis and inhibiting the formation of that gastric protective mucosal barrier, right? Because again, what's the acidity of gastric acid? Like a pH 2, right? So it's very, very acidic. So we need that mucosal barrier with lots of bicarbonate in order to prevent erosion of the gastric wall. And so we need prostaglandins to have that happen. And if you block that production, that's why you can have gastric ulcers that will form. And so NSAIDs are the #1 cause for gastric ulcers. With like H. pylori, those are the 2 #1 causes for that. And so again, if you have a patient who's complaining, or if you determine they have a gastric ulcer, the first question you ask is, do you take an NSAID? If they do you see it immediately, right? So that's one of the big things to be aware of. You can also see some effects, including edema and fluid retention. So you guys remember what effects the prostaglandins have in the kidneys? Yes, so prostaglandins typically vasodilate what? Which arteriole? The afferent arteriole, right? So again, remember the afferent arteriole is going to be heading into the glomerulus. You want to keep that dilated in order to keep blood flow going, right? So that way you can have good glomerular filtration, produce urine, all that good stuff. What you'll find is that for some patients, is that if you get rid of the prostaglandins, you're going to have a vasoconstrictive effect on the afferent arteriole, which you end up finding is that you can actually limit the amount of renal blood flow happening, limit the filtration, so you can actually have fluid buildup. So you can have edema happening there, fluid retention because of that, right? So again, knowing the basic physiology, you can get an idea of what the actual side effects are going to be in a lot of these cases, right? So it's pretty easy to go from A to B in these if you know the background on it. So also, when you hear that, okay, well, you can't take NSAIDs if you have renal failure, that is the same reason, because if patients are reliant on prostaglandins to keep that afferent arteriole open, and all of a sudden you give them an NSAID, you can see an acute decrease in GFR and cause an acute kidney injury. Okay, now it's reversible. As soon as you take away the drug, you should have that vasodilation happen again and get reestablish that renal blood flow. But it's one of those things where if you were to have it constrict for a long enough period of time, you can decrease oxygen supply to the kidneys. You can cause more long-term damage in some cases. So just be aware that's why a patient may have decreased renal function secondary to being given an NSAID. Now, if it's a normal healthy person, they can respond to that fine. Their kidneys are still working well enough. But if someone has kind of chronic kidney disease, they may be more reliant on those prostaglandins, right? And this will be a similar mechanism when we talk about our ACE inhibitors. You guys know what we use ACE inhibitors for? Yeah, for blood pressure. And you guys remember, so we have prostaglandins that dilate the afferent arteriole. What constricts the efferent arteriole to increase that glomerular pressure? Angiotensin 2, right? So that's why we'll see that if you give a patient like an ACE inhibitor, you'll see a dilation of the efferent arteriole, and that can also lead to a similar kind of effect because you lose that pressure. But again, that's not germane to our discussion right now. We'll talk about that more in the cardio section later on. Okay, so again, because of that, you can see that NSAIDs can actually inhibit the effects of a lot of your antihypertensives, and so that kind of goes back to looking at the ACE inhibitors. So again, if you're trying to give an ACE inhibitor as an antihypertensive, and all of a sudden you give a drug that decreases renal blood flow, what do you think the kidney's going to do to compensate? Say, hey, I don't have enough renal blood flow coming here, so what's going to happen to the renin-angiotensin system? Is it going to be inhibited or stimulated? It's going to stimulate, right? So again, anytime you have decreased kidney flow, renin-angiotensin system gets kicked up a notch, and so that will cause more angiotensin 2 to be formed. That's just going to make your antihypertensives, like your ACE inhibitors, less effective, essentially. Also going to cause problems with diuretics, which we'll talk about more later. Things like lithium, this can be a big one where patients will be on lithium, which, does anyone know what you use lithium for? Bipolar disorder specifically, yeah. So it's a mood stabilizer essentially, but because it gets handled just like sodium does in the body, because again, if you look on the periodic table, they're kind of neighbors. You'll see that if you cause sodium retention in the body because you're decreasing the amount of glomerular filtration happening, you also hold on to more sodium. We're going to hold on to more lithium as well, and so you can actually see toxicity from that. So again, just be aware a lot of renally eliminated drugs can be affected by NSAIDs, right? So especially if patients already have existing chronic kidney disease to begin with. So just be aware of that. You can also see some interaction with anticoagulants, so similar to what we saw with aspirin, this is going to be a more short-lived effect, but as long as the NSAIDs are on board, you can see additional bleeding, bruising, things like that if they were on something like warfarin or things like that. And of course, if they were having kind of erosion of that gastric barrier and they're on anticoagulant, you can see more serious GI bleeds, right? How could you tell if it was an upper versus like a lower GI bleed? Yeah, the color of the stool, essentially, right? So obviously they're kind of coughing or vomiting blood. That could be one clear sign. But if it was coming from the stool, and what color would it be? Yeah, dark and tarry, essentially. So again, when you're kind of metabolizing a lot of hemoglobin in the stomach, like that's where it was going to be coming out as. So it could be a sign that, hey, maybe the NSAIDs are causing GI bleed along with like their anticoagulants. So those are kind of things you can look for. As far as contraindications go, obviously if you're allergic, you want to do this. I mentioned before, this may actually exacerbate asthma in some patients. So I kind of drew this before. I'm going to try it again, even though my handwriting's going to be real bad. So I mentioned, if you have arachidonic acid, again, I'm left-handed, so this is extra difficult for me. I mentioned arachidonic acid can go through two pathways. So it can go down this way, where you have cyclooxygenase. Boy, this is really bad. Right, so you have a cyclooxygenase pathway, and this is where you get a lot of your inflammatory cytokines, prostaglandins, prostacyclin, all that gets formed. There's another pathway as well, and we'll talk about this more when we get to asthma in the pulmonary section, where you get leukotrienes being formed. Okay, so if I were to say give a drug like ibuprofen that blocked cyclooxygenase, you end up having a shunting of the arachidonic acid through this leukotriene pathway, and you form more leukotrienes. So those that are at risk, typically asthmatic patients, they may be more likely to have an asthma attack secondary to that, or an exacerbation. This is not for everyone. So for instance, like I have asthma, I could take ibuprofen, no problem. But if you have someone who has a history of ibuprofen allergy or an aspirin allergy, ask them what it is, and this is probably what it might end up being, is an asthma exacerbation. It's not a true blue like type 1 allergy, like anaphylaxis like you would normally see, because again, they may be claiming that they're having shortness of breath or difficulty breathing, but it's all related back to this leukotriene causing bronchoconstriction rather than simply having like their airways start to swell up and things like that, right? So, and again, as far as if they have a history of GI ulcers and perforation, things like that, you probably want to avoid these drugs, especially if it was related back to an NSAID in the first place. So just be aware of that. Won't talk too much about overdose stuff here. We'll talk a little bit about in the tox section, but again, not a lot to note with the ibuprofen. Again, if I had to have a patient overdose on aspirin versus like an NSAID like ibuprofen, every day of the week I'd rather ibuprofen. It's a lot easier to treat, and it's not nearly as kind of catastrophic as you see with some of your aspirin patients, but not super germane to our conversation today. Okay. Next we have acetaminophen, otherwise known as Tylenol. Does anyone know where the name Tylenol comes from? Already mentioned this. So the chemical name, and I'm not going to try to draw it out because it would take me probably 2 hours, but it's acetyl P-aminophenol. You can Google that, double check me. But you can actually pull the term Tylenol out of that acetyl P-aminophenol, essentially. So that's where the name Tylenol comes from, is the chemical name there. So you can wow your friends with your esoteric farm knowledge. But anyway, you also see this called paracetamol. Or para-acetylaminophenol, and so if you ever see APAP, that's where that comes from, essentially. And then, do you guys know what they call it in the UK? Yeah, they call it paracetamol, essentially. So if you ever, especially here in Orlando, we get a lot of people traveling, and so if ever someone's like, oh, I take paracetamol for headaches, that's what they're talking about is acetaminophen, essentially. Okay, we'll use this as an analgesic and antipyretic. We don't have a full idea what the actual mechanism is. Some people think it has more to do with affecting cyclooxygenase 3. Notice it's not a super good anti-inflammatory, right? So if I have I sprain my ankle, it's not going to really work a lot on that COX-2 that gets induced right at that site of inflammation. It's going to be working kind of more centrally. Again, we still don't have a full mechanism for how that works. We just know that it's probably something to do with cyclooxygenase, but it works, so we're just going to go with it, right? This is more used for analgesia, more used for as an antipyretic, right? So not really as a good anti-inflammatory drug. So, and notice here, the dosing, we typically are going to go very similar dosing strategies as we would do with ibuprofen, usually every 6 to 8 hours or so, maybe even more frequently than that, depending on if they're using kind of as needed basis. But the big thing to note here is not to exceed 4 grams in 24 hours. Why is that? Yes, liver toxicity. That is the #1 organ toxicity you see with acetaminophen, especially with patients who are taking it chronically. They're kind of chronically overdosing themselves over a period of time. They also need to be aware of other drugs that contain acetaminophen. So say, for instance, I have a really bad toothache. I go into the ER, I get antibiotics. What other drug do they give me? A really bad tooth pain. Hydrocodone, which is mixed with Acetaminophen, yeah, they give me Norco or they give me Lortab, right? That automatically has acetaminophen in it. So if I'm taking that every 6 hours for pain, and also I'm taking Tylenol on top of that, you can see how the doses start to rack up for a while. Does anyone know the dosage of acetaminophen in like Lortab? It's 325 nowadays, what it used to be. It used to be 500, yeah. So you see that Lortab 500. Now it's 325 or 7.5, 325. So again, the first number is the hydrocodone, the second number is acetaminophen. They reduced that dose down because of the liver injury that was happening for these patients who were overdosing on this hydrocodone product, right? So oxycodone very similarly had the dose dropped as well.
Why is acetaminophen in hydrocodone if you're already getting like a narcotic?
Because there's some synergism there. You get a little bit better pain relief by mixing the two than you would by just taking one or the other. And it kind of lets you take one pill instead of having to take two, essentially. Yeah, so there's some opioid analgesics you'll see come by themselves, but hydrocodone is one of those ones where for a long time we only had the combo for whatever reason. Yeah, and again, it used to be the #1 prescribed drug in the U.S. until it got scheduled 2. It used to be a 3, and then got moved up to a 2. So now it's kind of gone down a little bit and standing. But yeah, it's a very, very common drug, especially you guys are going to be able to prescribe opioids. You might be prescribing a lot of it depending on what your clinical situation is, right? So anywho, so again, be aware, let your patients know that, hey, this other drug contains acetaminophen. Do not take this in conjunction with Tylenol by itself, right? Because again, patients tend to self-medicate, and if they're not aware of that, then they can get in trouble. Now, can I take like hydrocodone and acetaminophen plus ibuprofen? Totally fine, yeah, and we actually recommend that. So in some cases, what you'll see is it will either cycle between the two drugs. So for instance, if I'm giving ibuprofen every 6 hours and I'm giving Tylenol by itself every 6 hours, I'll have them stagger it so that way they're getting something every 3 hours, and that way they get kind of better pain coverage. And so we do that very frequently for like our post-operative patients. We'll usually give them that so that way they're getting kind of something every 3 hours and they get better pain relief because of that. So one thing you can do. Again, not a ton of side effects you're going to see with this. It's very, very well tolerated. You don't see any of the GI effects. You don't see really many of the bleeding effects you see with your NSAIDs. So again, very, very well tolerated, but not really good for those acute inflammation. If you break an arm or something like that, like NSAIDs are going to be a lot better for that. Okay. Again, patients who consume alcohol chronically, they tend to be more likely to have hepatic damage when taking Tylenol. So they actually even reduce that max dose even further from the 4 grams down to like say 3,250 or something like that. They try to get the dose down so that way they're not going to be predisposing themselves to further hepatic damage. Okay, it doesn't mean if you drink a beer and then you have Tylenol, you're going to have liver failure. It's not what they're saying there. It's more of kind of a chronic issue than simply an acute issue, right? Oh, and that would be the drug of choice for a patient who's having, like, say, a pregnant patient who's having kind of minor aches and pains. Like, usually we'll recommend Tylenol because it's probably the safest out of the bunch for that. But we'll talk more about that when we get to kind of like women's health issues. Okay, so moving on, we have some systemic antihistamines. So yes.
Does that work synergistically with caffeine?
You will see it in combination products with caffeine. Yeah, so especially for patients who have like migraines or kind of chronic headaches, you'll see a combination of acetaminophen, caffeine, and then typically there's another, if you guys ever heard of Fioricet, it has butalbital, which is actually a barbiturate mixed in there. Otherwise, if you see products like Midol and things like that for like menstrual cramps, you may see like acetaminophen plus like caffeine in it. So maybe a little bit of synergy there. It's probably related to like some cerebral blood vessel kind of alterations, things like that. So. Anywho, histamine. Histamine is going to be kind of a key component in the allergic response. Typically, when you see kind of a triple response to inflammation, you're going to have redness, this kind of wheal due to edema, and this kind of flare reaction. So the vasodilation in the edema is coming a lot from histamine. There's other mediators involved, but histamine is one of the major components there. And so you see a lot of vasodilation, you see a lot of flushing, you're going to have a lot of heat, edema. We can give medication to help kind of prevent that by giving these antihistamines. So just kind of note the different layout of the histamine receptors. We're primarily going to talk about H1 receptors here today. H2 receptors are going to be primarily found somewhere in the bronchial smooth muscle, but the big one here is going to be the GI mucosa. So we'll talk more about H2 blockers when we get over to the GI section. Primarily today we're going to be talking about H1 receptors because again these are primarily the ones that are going to be affected with ENT concerns like if you're having conjunctivitis or sinusitis, things like that. These are going to be the things that H1 blockers can be useful for in blocking some of that vasodilation. So again, with our H1 receptors being activated, you're going to see increased post-capillary permeability. Again, you guys remember that phospholipase C secondary messenger pathway? You guys remember that? Just kind of put it there. See, this stuff kind of comes back every once in a while. But again, you're going to notice that the venules are going to kind of relax. You're going to have your capillaries become more leaky. You're going to have fluid leak out of that, essentially. You're going to also see you have increased mucus secretion, so both nasal, bronchial, GI secretion due to H1 activity. You're going to see increased smooth muscle tone in some cases, and then so you're also going to find there's some stimulation of sensory nerve endings and also bronchoconstriction. So these are the big things we're worried about patients having, especially like allergic reactions, are things like the bronchoconstriction, the mucus secretion, and then also the vasodilation. So again, when you have a patient who's having like an anaphylactic reaction, what does their blood pressure normally do? Goes down. They get hypotensive because they have a lot of histamine being released here, causing vasodilation, right? Also, they have a lot of bronchoconstriction, right? And that's why they can't breathe, and they're having a lot of edema forming in the airway. So you can see where histamine plays a really big role in all of these things. And so this is why we, when patients are having an allergic reaction, this is why we give antihistamines to block these effects, essentially. So H2 receptors, the primary thing they're going to be related to, at least for our purposes clinically, are going to be more for things like gastric acid secretion. So activation there is going to cause more gastric acid being released. You can also see more mucus secretion, and then typically it's going to be useful for things like smooth muscle tone to decrease, especially with like the esophageal sphincters and things like that. But we're going to talk more about those. So again, looking at by giving an H1 receptor antagonist, the main effects we're going to be seeing by doing this are going to be blocking that smooth muscle contraction. So this is going to work both in the GI tract and also the bronchial tract, which is, again, that's more important for an acute kind of allergic reaction. You want to have bronchodilation wherever possible. And we're also going to be helping with decreasing that secretion, the edema, hives, wheals, itching, all of that gets blocked when you give an H1 blocker. Okay. You can also see with certain of these H1 blockers, there's going to be some CNS effects that are associated with this as well. Now you're going to find there's a little bit of bleed over of effects here. Some of these drugs are going to have anticholinergic effects, right? So we're going to see there's going to be some antimuscarinic effects associated with some of these drugs. They can lead to their own kind of CNS side effects. But primarily, what you end up finding is that you have sedation being one of the major side effects of H1 blockers. So has anyone ever taken like Benadryl? What do you feel like afterwards? Feel pretty sleepy, right? You're going to be, even very large grown individuals feel very sleepy after a 25 milligram dose. Some people are very, very sensitive to the H1 blocking effects there. That also means it's going to be additive with other CNS depressants. So if people are drinking along with antihistamines, or if they're taking things like benzodiazepines or anti-anxiety meds, like they can also lead to some synergism there in CNS depression. And this is why it's available as an OTC sleep aid. So doxylamine, anyone know the brand name for that one? Heard of like Unisom? Doxylamine is the H1 blocker they put into that. And so again, we'll talk about generations of histamine blockers in just a second here, but you're going to find this is these CNS effects are going to be hallmarks of the first generation H1 blockers. Interestingly enough, you can also see some restlessness and excitation at higher doses, especially in kids. They tend to have what we call a paradoxical reaction, where instead of someone getting sleepy when you give them a drug, they get very excitable and they start bouncing off the walls. And so you might see this every once in a while, especially if you're like working in like a urgent care, if you're working like a PDR or something like that. Some kids, you give them a dose of Benadryl and you expect them to fall asleep, and they will just go hog wild, bouncing off the walls, tearing things down. They go crazy, right? We also see a lot of excitation, especially in overdose. So this is one of the things where, especially with teenagers, especially people who do not have access to like kind of prescription grade narcotics, they tend to like to overdose on these H1 blockers, right? So has anyone ever heard of someone doing like triple C's? Okay, I'm trying to think of any other, you kids these days, what kind of drugs are you guys taking? All right, well, anyway, so there's a drug called Corsetin cough and cold. That's some people will refer to that as a triple C. Anyone ever heard of Corsetin? It's a common over-the-counter cough and cold medicine, essentially. But basically, people will do high doses of that for the antihistamine effects because it causes highs in some cases, hallucinations. You can also see like seizures occur from this. So over-the-counter cough and cold medicine is a common thing people will overdose on in order to get high, essentially. So it's one of the big things we run into with these type of drugs. And then we'll find that the way to combat this is we actually have second generation antihistamines that actually do not cross the CNS. And so essentially, you guys remember the blood-brain barrier? It's meant to keep drugs out essentially. Well, the first generation drugs, they can get across very, very easily for the most part. But the second generation, what's nice about their structures is they actually have a permanent positive charge put on them chemically. So that way they just bounce off that blood-brain barrier. So we'll see with our second generation drugs, they work good for kind of a peripheral allergy reactions, but they don't really get into the CNS. They don't cause sedation. So that's one of the big reasons why you'll use the second generation drug. I'll show you a list of these in just a minute here. So other non-specific effects, you're going to find that our first generation drugs that get up into the brain, they can have good antiemetic action. So we'll see this being used for things like motion sickness. We use it for things like vertigo. They have good antimuscarinic effects. So typically, the patient's having a lot of secretions. Antimuscarinic effects will help to dry that out as well, right? Remember the parasympathetic nervous system, when activated, causes a lot of secretions. Remember do you remember the mnemonic I told you guys for cholinergic effects, muscarinic effects? Not mud pods, that's for metabolic acidosis. Dumbbells, yes, dumbbells, right? So again, you're having a lot of secretion. So again, the bronchoria, seeing urination, salivation, this kind of does the opposite effect, right? So you're blocking a lot of secretions. Patients tend to dry out. So it's good if you're having a lot of rhinitis, a lot of postnasal drip. This can help with that because it helps to dry the patients out essentially. And also a little bit of anti-serotonergic effect. Clinically, we're not going to talk about this so much here, but we'll see that there's some drugs that can have anti-serotonin properties. Clinically, not super useful, but these two are some of the big ones, right? So when we look at some of these drugs here that are working, they're very useful as antiemetics. They can also help with the drying effects. So as an antiemetic, you're going to find they work because antimuscarinic effects help as an anti-emesis. We'll cover this when we get to GI as well. They also work on the chemoreceptor trigger zone, so they kind of block the effects there, which is nice. And then we'll see that, you guys ever heard of Phenergan? Promethazine, this is a very common one we'll use as a very, very strong antimuscarinic actions. So this works very, very well for motion sickness. I remember one time I had a really bad cold and I was in farm school, and my aunt gave me one of these. She had leftover. Again, not legal, so I shouldn't admit this over the internet, but completely knocked me out, right? I was dry as a bone, but completely knocked out for like 8 hours. So best sleep I ever had. And again, because of the antimuscarinic actions, you have decreased nasal, bronchial secretions. All that is very good for drying patients out, especially if they're having a lot of postnasal drip and that's keeping them awake, or they're coughing a lot because of that. This helps to dry them out. So some indications we'll use for H1 blockers include allergic reactions. So we'll give this they're having either due to drug hypersensitivity, insect bites, whatever kind of allergic reaction, you can use H1 blockers. Motion sickness, especially due to vestibular disturbances. So vertigo is a very common indication for some of these. As an over-the-counter sleep remedy. Again, this is not, we like to use these for as short a term as possible because you tend to find that people will become dependent on this after a while, and so they end up having rebound insomnia whenever they come off of it. So again, recommend for short courses of insomnia. And then we'll also use this as an adjuvant role in anaphylaxis. So we'll give this along with some other drugs. You guys know what other drugs we might give for anaphylaxis? Steroids, absolutely. And then what do you like, jab in your leg? Epinephrine, yeah. So those are kind of the big three drugs you give. You give antihistamine, usually Benadryl, corticosteroid, and then you give epinephrine for that. So as far as adverse reactions go, again, sedation. Well, some people take it for that, but you can see this happen a lot in other patients, and that's why we recommend, especially with your first generation drugs, is that you don't operate heavy machinery, don't go driving your car until you know how the drugs are going to affect you. You may see some GI disturbances. This is not super common, but then the antimuscarinic effects can be a problem for some patients, either due to dry mouth, they have, say, urinary retention, especially had problems with that previously, blurred vision, all that can be issues there. And then occasionally you see some hypersensitivity. This is not super common though, because again, it helps to kind of block allergic reactions. You see this more with kind of topical preparations, mainly due to having a reaction to other ingredients in that product, not the actual drug itself. Okay, so here are our antihistamines we're going to talk about. So we have our first generation. You have things like chlorpheniramine. This is the one that comes in that course-eating cough and cold I kind of mentioned. We have dimenhydrinate, which is Dramamine. Everyone's heard of Dramamine before? Probably. Yeah, it's probably a kind of common one. Then you have diphenhydramine, which is Benadryl. I'm sure everyone's heard of Benadryl. Everyone's probably taken Benadryl at some point in their life. And so these three are going to be over-the-counter products, right? Diphenhydramine is also nice because it's going to be IV available. So this is kind of our go-to IV histamine blocker. You also have hydroxyzine, which is Atarax. This one's going to be prescription only. You see this used a lot for emesis and for vertigo, things like that. This one is a common drug that gets mixed with a drug called hydralazine. So imagine hydroxyzine, hydralazine. It's a very common medical error to get those two drugs mixed up. Hydralazine is used for high blood pressure. This one's used for allergic reactions. You don't want to really mix those two up, otherwise you might give the wrong one to your patient, and then all of a sudden their blood pressure bottoms out, and you're like, what's going on? It's usually because of that. We have meclizine, which you can find in a drug called Antivert, and then promethazine or Phenergan. This one's actually nice because it comes as a suppository. So if you had a patient who's having significant nausea, vomiting, you could give it as a rectally administered drug, so that way they can keep it down, or they avoid having to give an oral medication if they were not able to keep anything down, essentially. So again, these are first generation. These have good CNS penetration. So this is where you're going to see a lot of the sedation happening here. So we're going to see a lot of the anti-emetic effects, and you see a lot of anticholinergic effects. This is all CNS mediated. Okay. That's a big thing. You don't have to know all the differences between the highs and mediums and all that. Just know that because they're first generation and they get to the brain, they can have all these effects. Okay. On the other hand, we're going to have our second generation drugs. You have things like cetirizine, fexofenadine, and then loratadine. Those are the three big ones that you're going to see. Most of these have gone over the counter. I think all of them have gone over the counter at this point, which is nice. You're going to find that these do not cross the blood-brain barrier. So these tend to have the lowest side effects out of the bunch. They'll work for peripheral, allergic reactions, but they do not cause a ton of sedation. They do not cause antiemetic effects, and they do not have anticholinergic effects. So again, if you had a patient who had a lot of rhinitis, they're having a lot of postnasal drip, and it's keeping them up at night, these second-generation drugs are not going to help with that so much, right? Give them a first-generation drug that will dry them out. So you can keep in mind what you're trying to treat, and it'll guide you as which one you want to give. So these second-generation drugs are a lot better for kind of more consistent maintenance therapy of allergies, especially if it's like seasonal allergies or they have year-round allergies. These drugs are good to take every single day, right? Because they're not going to cause a lot of side effects, and they can prevent a lot of those allergic effects from happening. Versus your first-generation drugs, you really only want to give it as needed if they're actually having the effects actually happening there. Okay. You're going to see that there's some new prescription products that are going to be enantiomers of some of these. So I see like levocetirizine, there's like desloratadine. You don't need to use those. Just use over-the-counter kind. It's going to be cheaper for your patient, and they work just as fine. There's actually no. They're just trying to get new patents and get more money out of people by selling a brand name drug. So, again, not claiming you guys need to be cynical right now, but you'll become cynical as time goes on. So don't worry about that. The other nice thing is the second generations tend to have longer half-lives, so they stick around for longer. Tend to only have to give these drugs once or twice a day. Most of the time, it's just once a day. It's supposed to have like a extended release preparation. Most of the first generations have to be given multiple times a day. That's kind of the other downside to those. And there's also an intranasal antihistamine called Zelastine. I don't see this used super commonly. Systemic therapy is just a lot easier to do than having to use a nasal spray. But again, by giving something just nasally, you're going to notice low systemic side effects because not a ton of that gets absorbed from the nasal mucosa. Again, Zelastine or Astelin, you'll see this most often as a nasal spray over the counter. Again, don't like to use it too frequently because, again, most patients don't like to have to use a nasal spray. It's easier just to take a pill in a lot of cases. But some side effects you might see include things like bitter taste or like epistaxis, which, what is that? Yeah, nosebleeds. You can sometimes see, especially if you're having kind of local drying effects, that can sometimes lead to sometimes that skin kind of cracking and lead to a little bit of bleeding there. So that is one potential side effect. Here you can just see as far as patient education goes, it's important to educate them on how to actually use the product. So again, when you're ever using these nasal sprays, for one, make sure you kind of blow your nose beforehand. Try to get rid of as much gunk in there as you can so you have good access for the drug to the nasal mucosa. Typically you want to tilt the head down and then you'll angle the spray away from the septum. So you can either do like kind of use the opposite hand for that nair when you put it in. And then essentially, you don't want to have the head tilt back because otherwise you end up having a lot of the drug drip back into the throat. You don't necessarily want that. You really want the effects in the nose if you're going to use it there. And then make sure they're cleaning the thing very well. You don't want a bunch of gunky nasal stuff to be left around. And again, should you share with your family members? Stuff like no, if it's typically ophthalmic, otic, if it's nasal stuff, don't share. It's kind of gross. So just get your own. Okay. All right, so next we'll talk about a few ENT corticosteroids being used. So again, how are corticosteroids working? The same as the ones that our body produces, like cortisol or hydrocortisone. Essentially, they have to get into the cell themselves. It has to go down to the nucleus, and that will change gene transcription. So basically, prevent production of a lot of those inflammatory cytokines. Again, this is working from a global perspective, so you're kind of inhibiting all downstream anti-inflammatory effects there. So what you're going to see is that you're going to have glucocorticoids are going to be decreasing the activity of all of your different immune cells. You're going to be seeing decreased mucus secretion. You're going to have decreased smooth muscle relaxation there, or increased smooth muscle relaxation of things like the bronchial muscles. You're going to have decreased leak from the endothelial cells. So you're going to have less vasodilation. You're going to have less leaky capillaries, essentially. So it kind of helps with all aspects of the of allergic reactions, basically from the top down, essentially. Because again, if you're looking at a patient having an acute allergic reaction, they've already started to release histamine. They've already started to release a lot of those inflammatory cytokines. By giving an H1 blocker, you're only dealing with what kind of histamine is already being released. Glucocorticoids are going to take time to work because they're basically changing the ability to actually produce those inflammatory cytokines in the first place, right? So again, when you're looking at onset of action, glucocorticoids tend to be slower than a lot of your other drugs, but they tend to be way more powerful from a systemic standpoint. That makes sense? So, and again, we mentioned there's a lot of side effects associated with giving systemic corticosteroids. You guys remember any of the side effects? Worsen cataract formation, glaucoma, osteoporosis with chronic use.
Growth retardation.
Yeah, potential growth retardation. Yeah, adrenal suppression, and then eventually an adrenal crisis if you were to withdraw the drugs. What happens to your blood sugar? Goes up. What happens to your blood pressure? Typically, it's going to go up, if anything, due to fluid retention, right? So, some of those mineralocorticoid effects. So, again, think about your patients, think about hypertensive patients, your diabetic patients. Those all tend to be worsened when they're on corticosteroids for the most part. So, the idea is if you can use something more locally acting, you're going to have a lot less side effects systemically and only have the effects of the place where you need them, right? So, this is where a lot of our nasal corticosteroids come in. So there's several of these that are available. So you have things like beclomethasone, budesonide, flunicillide, fluticasone, mometasone, and triamcinolone. Because these are so frequently used, I would recommend remembering all of these as your nasal corticosteroids. Keep in mind that it's very easy to get these mixed up with the inhaled forms that we use for, anyone know what we use those for? Inhaled corticosteroids? Asthma, yeah. So we use those for asthma. So it's very, very important to, some patients may be on both. They may be on an asthma preparation and a nasal preparation, but this is a common medical error as well to get these screwed up, especially like fluticasone. Over at Nemours, our formulary nasal steroid is fluticasone or Flonase, and it very often gets mixed up with Flovent, which is the inhaled form for asthma. Right? We'll talk about that later in pulmonary, but just note that these all have inhaled forms, and the brand names are easy to get mixed up because you have like Rhinocort versus I'm trying to think. Actually, no, mometasone is a good one because you have Nasonex versus Asmonex, and they sound so similar. It's very easy to see people screwing that up. So, anyway. So again, you will see these used very often for allergic rhinitis, and especially vasomotor rhinitis. There's not a ton of side effects associated with them, but you can see epistaxis potentially, possible septum perforation, and some unpleasant taste. But unpleasant taste more common, but really septum perforation, I've never seen that. It's very, very rare. The other thing to note is that how long do you think these take to work? A couple of days to really start to kick in because they have to get down to those cells. They have to go in and start to affect production of a lot of those inflammatory cytokines. So it takes time, and you have to use these consistently. So it's one of those things where you can't just do it a couple of days, you feel better, and then all of a sudden you stop taking it because guess what? Symptoms are going to come right back, especially if it's kind of an environmental allergy you're dealing with or if it's year-round allergies. You have to use it consistently, otherwise it's not going to work super well. Patients may say, hey, it stopped working for me. It's probably because they're not taking it correctly. Okay, so that's the big thing to know with these. So not really any contraindications to using these locally acting products, which is nice because you certainly see lots of contraindications systemically. And again, the same instructions that you'd use for the other nasal spray we talked about, so I'm not going to labor that point. Now, we do have some systemic options that we can administer, especially for patients that kind of need kind of a nice kick in the inflammatory cascade. If you need to kind of tamp things down very quickly, we can give a systemic option, and then basically we'll end up tapering off of that. So this is more used for like, say, a week 5-day course of therapy when using systemic corticosteroids for these kind of ailments versus like a nasal corticosteroid. You could use that year-round, no problem, right? So these are going to be for short course uses here. But you have things like dexamethasone or Decadron. This one is very commonly used. We give it orally. It has an IV form that's available as well, which is handy to use. And again, it's going to be working as a synthetic adrenocorticosteroid. You can use it if patients having really severe allergic rhinitis, or if they're having, say, like a hypersensitivity to really anything, but like drug sensitivities, if they're having any kind of anaphylactic reaction, this can be administered for these patients. Note here, you're going to have you can worsen things like hypertension, CHF, fluid retention due to the mineralocorticoid effects. You see glucose intolerance. You can see lots of issues like hirsutism. You have potassium loss. All these different problems that come about from these. Again, we see the same effects happen if someone had kind of a normal hyperadrenal state anyway. Same thing happening here. And also note, if they're on it for long periods of time, you can see decreased ability to fight infections. I can see secondary infections happen from this, which is why we like to use these for very short courses. There's some disease states where we're going to use them more consistently, things like rheumatoid arthritis. But for these kind of indications, a week, 5 days, maybe at the most, so you're going to be using these drugs. So again, as far as interactions go, just keep in mind that look this stuff up beforehand. But certainly, if they are on diuretics, corticosteroids are going to make that worse, right? Because you're going to be holding on to more fluids due to the mineralocorticoid effects. Think about things like anti-diabetic drugs. They're going to work worse because these corticosteroids are causing your glucose to go up. So a lot of these are kind of just intuitive sort of things. But there's going to be a little bit of CYP metabolism that goes on for this, and so things like macrolides can actually inhibit that. So again, be aware. So especially if you're treating them for, say, rhinosinusitis, you thought it was bacterial, and you're also giving them some Decadron, like you see how that could lead to a side effect. Okay. As far as contraindications go, nothing really significantly. Why do you think I'd put systemic fungal infections here?
Would make them worse.
Yeah, potentially, because it's tamping down the immune system, it potentially leaves you less likely to be able to fight off that fungal infection yourself. So that's usually the reason why I would say that there. But again, it's not something that will come up very often clinically. Now, again, if you were on a corticosteroid, and we're just talking about dexamethasone here, but this applies to all orally administered steroids. If you're on it for greater than a week, you have to taper, right? Because again, negative feedback loop, your adrenal glands say, hey, there's enough corticosteroids floating around, I don't need to produce anything. So you're going to have adrenal suppression. That's just a natural effect of having the drugs around. If it's on it for 5 days, you don't have to taper, right? So it has not been long enough for the adrenal glands to really stop production altogether. If it's longer than that, you have to build in a taper. Okay, so that's a general rule of thumb there. So again, if you do discontinue it abruptly, if it's been over a week, that's when you're going to run into adrenal crisis. They have low blood pressure, all kinds of other nasty effects can happen there, hypoglycemia, all kinds of things. Also, just keep on the secondary infections. If they start to feel like they're getting sicker, could be a result of that. Probably come back in and get checked out. Another common one we have is prednisone, or Deltazone's a brand name for that. We also have prednisolone. This is actually the liquid form that we use a lot for especially pediatric patients and whatnot. So again, Orapred is a common brand name for the liquid formulation there. Again, similar side effects, similar activity. The only thing that really changes between prednisone, like dexamethasone, is really how long the drug sticks around for, so the half-life and the dose you're going to give. So the relative potency is going to change. So for instance, like, for prednisone, a normal dose is usually, say, like 1 milligram per kilogram per day versus like dexamethasone, you may do like, say 0.6 or something. So, the dexamethasone tends to be a little bit more potent than prednisone, but same side effects, same things you'd be looking for if you're administering the same things to worry about with tapering. If you're on it for more than a week, all that still applies. Okay. So those are probably the two main corticosteroids you're going to be dealing with, at least on an outpatient basis. There's certainly more than that, but we'll talk about those more in other sections. Just trying to give you guys an overview right now. Okay, next is our decongestant. If I run over a little bit, you guys okay if I finish up? Okay. First off, we have our oxymetazoline, otherwise known as Afrin. Anyone ever heard of this drug? Common over-the-counter nasal decongestion. This one works by actually being an alpha agonist. You guys remember the difference between alpha 1 and alpha 2 receptors? What does alpha 2 do? Yeah, so alpha 2 actually ends up vasodilating because it works centrally. Remember, that's the one that kind of turns off release of catecholamines centrally. What's interesting is this oxymetazoline actually is an alpha 2 activator, but what you find is that when you apply this stuff locally at very high concentrations, you lose that selectivity. So again, selectivity only happens within certain dosing ranges, but when you get a high concentration, this will actually activate alpha 1 receptors as well. And alpha 1 receptors, when activated, does what? Vasoconstricts, right? So I'm having allergic rhinitis and I'm having a lot of vasodilation. I get a lot of leaky capillaries and losing a lot of that fluid leaking out as a form of a lot of snot, right? You may think it's funny, but it's not. You're going to find that by activating the alpha 1 receptors, you're going to vasoconstrict, and that will help to dry things out quite well. So very, very good drug. Note though, you really do not want to use it more than 3 to 5 days. Okay, this is an important counseling point because patients become dependent on this after a while. So they get it's not really addiction necessarily, but it's very, very tolerant to these effects. And if you withdraw this after say 5 days worth of consistent use, you end up having what we call rhinitis medicamentosa. Basically is rebound rhinitis. It tends to be a lot worse than what it was in the first place. And so I remember when I was on rotations in a CVS pharmacy, we had this one pharmacist who had 3 bottles of Afrin, one on either side of the counter, one in the middle, because he would just be going along his day, just taking a little sniff here, a little sniff there, because that's how much it took just to keep him like normal, right? Because he'd been on the stuff for so long. So he obviously was not educated very well. But you guys will be able to educate your patients no more than 3 to 5 days. Even like stuff like this when we prescribe in the hospital, we have hard locks on how long you can prescribe it for. So after 5 days, it just falls off the MAR essentially. Very good drug though for the short term. And actually, this is a really big one we worry about because if kids were to swallow this stuff because it's so potent and because it is so available over the counter, a lot of people have it in their homes. Kids that get into this, it actually causes the central alpha-2 effects and can lead to really bad hypotension, bradycardia. So it's very, very dangerous for kids to get into. But very good for adults if they're having congestion. And then you have your pseudoephedrine or Sudafed. So is this one over the counter? It's behind the counter. Yeah, so technically over the counter, but it's now behind the counter because you can make what out of it? Methamphetamine, absolutely. So we don't want people to make methamphetamine, so we said, well, let's go ahead and put it behind the counter. Let's restrict how much people can buy in a month to avoid people going around and buying up whole huge amounts of it. But so that's why it's behind the counter, because of the meth potential. So anyway, this also works as a decongestion. This is specifically working as an alpha-1 agonist. And so, but this is a systemically administered drug. This is orally administered. And so this works more systemically than what you would see with like an Afrin type product, right? So again, it's not just going to work on the alpha-1 receptors in the nose, it's going to work everywhere else. So what do you think your blood pressure does? Goes up, right? So this is why we do not recommend it for patients who have hypertension, because it can worsen that. Especially if they have any other side effects, including tachycardia, headaches, all of that can be related back to the alpha-1 effects seen with these drugs. So again, be very aware of that, especially if you have a hypertensive patient. Recommend against utilizing this. Now, if you see like Sudafed that's on the actual shelf out in the pharmacy, like what is in that product? Let's say like Sudafed PE. It's actually phenylephrine. Okay, so phenylephrine is not the same as pseudoephedrine. Phenylephrine is actually a pure alpha-1 agonist as well, but when you take it orally, it's a super wimpy drug. It really does not work that well. So that's why you recommend your patients not actually use that. Actually, if they need something for their congestion for short-term use, they're not hypertensive, have them get the behind-the-counter product, right? Because that's going to work a lot better for them. Can't tell you how many people I see at the pharmacy, and they're like, oh, this stuff doesn't really work for me. I'm going to go ahead and take it anyway. I'm like, no, you need the good stuff. Go get it behind the counter, right? Just don't make meth out of it. That's the only thing I recommend. Okay. Mucolytics go. We have one drug in this category. It's called guaifenesin. Mucinex is a common brand name you'll see for this one. Again, over the counter. This one is a mucolytic or an expectorant. Helps you to kind of break down kind of the thick, kind of tenacious mucus in the lungs to try to help you cough it up. I'll never understand why you see this mixed with cough suppressants, because you're like, well, I'm trying to give something to break up the mucus, but then I'm trying to prevent them from coughing. Doesn't make a lot of sense, but you'll see the combination used pretty frequently. The biggest thing to note with this drug is it has like really no side effects whatsoever. It's very, very benign. They need to drink lots of water with it, because if they're dehydrated, that mucus is also dehydrated, and even though you're trying to break it up, it needs fluid in order to help you kind of expectorate it a little bit easier. So tell them to drink lots of fluids along with this one. Of course, let them know that, hey, they're going to be coughing up lots of gunk, but hopefully once they get rid of it, then it'll be kind of more manageable. And that's it. I thought I covered dextromethorphan here, but apparently I did not add that in this section, so we'll probably talk about that later somewhere. Yes, ma'am.
Is there an ingredient in Afrin that causes dependency, or is it just
Causes what?
like dependency, or is it just?
No, it's just the fact that your body gets used to having that vasoconstrictive effect around, right? So, for instance, if I'm constantly activating those alpha-1 receptors, what do? They downregulate or do they upregulate?
What upregulate what?
So the alpha guys. Shh. So if I'm constantly activating alpha-1 receptors, should they downregulate or upregulate? They downregulate, right? Because I'm having too much of that activation there of those receptors. So all of a sudden, if I take that drug away, Now all of a sudden I have fewer alpha receptors to be activated. Now the reaction is going to be the cause of vasodilation essentially, right? Because I'm relieving that pressure of the alpha 1 effects. Fewer receptors can be activated by natural, like epinephrine and norepi. So you end up seeing reflex vasodilation essentially. So that's why you get that effect. Very similar to what you saw, like if you have a patient on a beta blocker, the blocks beta 1 effects on the heart. If you have that on for a long period of time, then you take away beta blocker, all of a sudden you get reflex tachycardia. So this is one of those things you see with the cardiovascular system. You end up getting rebound effects very frequently. The opposite of what the actual drug was doing itself. Yes, ma'am.
Why would you get dexamethasone and digoxin together to cause arrhythmia, but digoxin is an antiarrhythmic?
If someone happened to be on digoxin, say chronically, if say for AFib or their CHF, and they happen to come down with a cold, or they come down, pretty significant, rhinitis or something, like you may prescribe them dexamethasone on top of that, even though it's unrelated to what their cardiac issue is. But that's why you as an astute provider will look at their med list and, hey, you're on digoxin, maybe this isn't so good, or maybe use a reduced dose or something like that. Any other questions? Okay, so that is the end of the material for test 1. Hopefully the Pharmapocalypse will not be so severe this year, but we're going to have a good review session next week. I know it's Thursday, right? I think we meet Thursday. We're going to have a good review session on Thursday. The questions will be very representative of what should be on the test. And then we'll have the test next week. And everyone's going to pass and do really wonderful. I expect the average to be 96, 98, roughly. So, all right, so I'll see you guys next time.